Hi, I'm Ashley, and I'm going to talk to you about the art of giving effective feedback. Research has shown that feedback in the clinical area occurs infrequently, and when it does, it is ineffective. There are many reasons to ineffective feedback, which we will talk about in more detail. When feedback is done effectively, it can be uplifting and illuminating for the giver of feedback and the receiver. This is true for constructive or critical feedback when a plan for improvement is made going forward. Feedback which is not effective for one reason or another can lead to confusion and continued poor performance from the learner. Let's talk about barriers to giving effective feedback. There are many reasons feedback is not well received or given. This is a skill like any other we can practice and learn. The following are some examples of barriers to effective feedback. Undermine learner's self-esteem. This is challenging for a supervisor or assessor working with a person you like and respect. You don't want to offend or dent their confidence, but it is our responsibility to keep patients safe by engaging in feedback with the learner to improve practice. Avoidance of appearing critical. No one wants to be the bad guy. We all want to be liked, but there are skills you can learn to enable a two-way discussion with the learner and make a plan for improved practice. Lack of confidence in giving feedback. Some experienced practitioners do not have a lot of feedback experience or education. This can be challenging to find a role model for feedback practice. Exposure and practice of giving and receiving feedback is important. Lack of advice on how to improve behaviour. It is not enough to inform the learner they are practicing ineffectively or poorly. For feedback to be effective, the learner must have time and opportunity to self-assess and then both discuss a plan for improvement. Feedback is too general. We have received and possibly provided general feedback. For example, you did a really good job there. Although this is positive, it is unhelpful. Feedback should be specific. Then the learner will know exactly what they did well and it is reinforced. For example, the way you got down on your knee to communicate with the patient is a great example of effective communication and person-centred care. The learner becoming defensive. This is a challenging conversation. It is important for the learner and the supervisor to develop a respectful relationship where adult conversations can be facilitated. Opening by asking the learner to self-evaluate their practice is a good place to start and elaborate from there. There are many more barriers to effective feedback. It is important to realise if we can create a feedback culture where we all seek and discuss feedback, it makes it a lot easier to have honest, effective feedback discussions. The aim is to identify gaps in knowledge and practice together and make a plan for improvement. For health professionals in particular, it promotes reflective and experiential learning, which involves training on the job and reflecting on experiences, incidents and feelings. More importantly, feedback aims to develop performance to a higher level by dealing with underperformance in a constructive way. We will now look at examples of good feedback practice. Feedback models can be adopted to assist with providing feedback. An example would be the feedback sandwich. This starts and finishes with positive feedback, and the more constructive or critical feedback is sandwiched in the middle. This can be useful in everyday clinical practice. However, this can lose effectiveness, leaving the person receiving feedback always waiting for a but in the middle. Ensure you give positive feedback on its own when the opportunity arises. Chronological feedback. This focuses on a reflective observation, reiterating events which occurred back to the learner. For example, the first thing you did well when you entered the room was introduce yourself to the patient. Then you proceeded to talk to the patient and explain what you were doing as you performed observations. This can be helpful for short feedback, but you can get bogged down in too much detail in a longer session. Finally, the Pendleton model. This is more learner-centred, promoting conversation and identifying action plans and goals. Encourage the learner to reflect on what went well, creating a safe environment. The facilitator elaborates on what went well, highlighting positives, then encouraging the learner to reflect on what was challenging, providing suggestions for improvement, creating an action plan. The main idea is to use open questions to give the learner the opportunity to reflect. What do you think went well? What do you think could be done differently? What could be improved? To set a positive feedback culture, we should be seeking feedback on a regular basis. Feedback is a multifactorial process: giving, taking, and asking. A great feedback culture promotes upward feedback. A model where hierarchy has no role. Senior staff seek feedback from more junior members of staff, and they in turn feel confident enough to provide this. This sets a great example for staff. We can all learn from each other. It should be ongoing, regular, and supportive. Opportunities should be made to follow up on any action plans implemented. To summarise, feedback is not a one-way street. It should be a learner-centred, two-way conversation requiring both the learner and supervisor engagement. Feedback should be timely and specific. Learners should be self-evaluating their performance. Plan in advance and think about what you want to achieve. And be aware of non-verbal cues. And very important, self-reflect after the feedback session is complete. Good luck.